Good afternoon and Assalamu alaikum. I'm Mohammad Azan, a second year MBBS student from Central Park Medical College. It is an honor to introduce our distinguished chairs for Plenary Session 7, Special Topics in Rheumatology.
First of all, we have Professor Sumaira Farman Raja, Chair, Scientific Committee, PSR Conference, ACF and Head Department of Rheumatology, National Hospital, Lahore.
Professor Amjad Naseem, Head Department of Rheumatology, Fauji Foundation Hospital, Rawalpindi.
And Dr. Ghulam Shabbir, Consultant Rheumatologist at Medicare Hospital, Multan.
And they are joined by Dr. Asadullah Khan, an energetic and insightful clinician, as co-chair. Please join me in welcoming them to the stage. However, unfortunately, they could not be here with us today, so we would like for Dr. Naseemullah to join us. Dr. Naeemullah for us to join us, please.
As we continue with our new plenary session, we now have the honor of hearing from Professor Tsutomu Takeuchi, former president of APLAR and professor of medicine at Kyoto University School of Medicine, Japan, who will be speaking on IgG4 related disease, unraveling the diagnostic enigma. Please everybody give a huge round of applause for Professor Tsutomu Takeuchi.
Thank you very much. Kind introduction. Dear Professor Harman and the Professor Ahad and the Sahid, thank you, and the organizing committee, thank you very much for giving me such opportunity. This time, I would like to talk about the IgG4 related disease, IgG4RD. This is a rare disease. Have you ever experienced this disease in your clinics? I don't know what is the recognition of this disease. I would like to a little bit overview about the disease, this IgG4 related disorders. The initial concept, the initial recognition of the disease is made by Mickley's disease. That is more than 100 years ago. He described a patient with lacrimal and glandular swelling that is similar to the disease, such as the Sjogren's disease, yesterday I talked about. However, the clinical features are different from those with Sjogren's syndrome. For example, the male-female ratio, the male-female ratio equal, rather than female predominant in Sjogren's disease. Also, dry symptom is always milder than that of Sjogren's disease. And it is peculiar to note that this disease is associated with autoimmune pancreatitis. To this end, some researchers in Japan recognized, they took the blood of the patient with the previous known as Mickley's disease. He found that the serum IgG4 level is very high. That is also recognized in the autoimmune pancreatitis. And then the disease is called IgG4 related disorders. The initial description of Mickley's disease, dry symptom is milder than that of Sjogren's. We described in 2000 the year publication right here. After this publication, as I said, the Dr. Yamamoto in Sapporo Medical University in Japan found that serum IgG4 is very high in this subset of disease, previously known as Mickley's disease. And then we made a diagnosis criteria for IgG4RD from Japan, the year 2008, followed by 2012. And now we are recognizing this new disease, IgG4RD, previously maybe known as Mickley's disease. So, what is IgG4? If you can recognize the subclass of IgG, such as IgG1 on the left, IgG2, G3, and G4. Particularly, you may aware of the allergens that is reactive to IgG1, but not G2, G3. IgG4 is the main subclass reacting to allergens. So, somewhat IgG4 is related to allergic disease. And then there is no C1q binding domain, C1q binding activity in IgG4. And also, the binding ability to Fc gamma receptor is weaker for IgG4 compared to IgG1 or IgG3. So, IgG4 is a unique subclass of immunoglobulin, somewhat related to some allergic reactions. And then the disease, IgG4-RD, you may be aware such as the enlargement of lacrimal gland on the upper panel. Also, you may have some CT scan or PET scan, not only observed in lacrimal gland and salivary gland. Also, you may be seeing some signals in pancreas and the intestine or all other sites, in addition to the big lacrimal gland right here. And you may be aware that the pathological findings of the lacrimal gland, salivary gland of this disease is that extrafollicular germinal center formation in addition to the enriched lymphocyte in germinal center. And also, IL-4 staining in this time is positive, as well as IgG4 producing plasma cell infiltration in the region. So this is very unique. This is not totally different from Sjögren's disease, right? What is the pathogenesis of this disease? IgG4 is a unique subclass of IgG. We may expect that is somewhat related to some allergic reaction that is driven by Th2. So when you look at the B cell producing IgG4, what is a helper cell to help the B cell to produce IgG4? Here we identified Th2 in addition to TFH2. You know that follicular helper T cell, known as TFH, we can divide TFH into TFH1, TFH2, TFH17, and TFH117. The cell called TFH2 is predominant in this disease to promote B cell to produce IgG4. Here is the central picture of the pathogenesis of IgG4-RD. As a result, the plasma cell is predominantly producing IgG4 rather than IgG1, 2, 3. So this is the picture. And this is, for example, the TFH2 picture right here. The main cells, particularly main T cell, is TFH2 in this disease. What is the clinical feature of IgG4-RD again? The major salivary glands enlargement, lacrimal gland enlargement. In addition to these two, exocrine gland enlargement, you may see some pancreatitis here. This is a major 3 clinical signs symptoms. And then there are several others, such as the patch meningitis here, the thyroid gland, aorta. This is very similar to Takeuchi arthritis. This is observed in the IgG4-RD. And orbits, lungs, bile ducts, kidney, everything. This is a systemic disease. So, the definition or criteria for IgG4-RD is somewhat delayed because we proposed the Japanese criteria for IgG4-RD in 2011. Now we have ACR EULAR criteria for IgG4-RD in 2019. So we have a lot of experience of IgG4-RD. I don't know why that is prevalent in Japan. But anyway, This is a very complex the criteria for IgG4RD in HCR EULAR criteria. The first step entry criteria is clinical and radiographic involvement of typical organ, such as pancreas, salivary gland, bile ducts, orbits, kidney, lung, aorta, retroperitoneum, patch meningitis, thyroid gland. These are the typical, the characteristic clinical, in addition to some imaging data, and exclude a long list of the exclusion criteria for the disease, right here, and then inclusion criteria, the long list. And then you may account the inclusion criteria, the total score is more than 20, are finally diagnosed of IgG4RD. This is the representative CT images of IgG4RD, such as the orbit, enlargement of lacrimal gland, enlargement of a maxilla sublaryngeal glands, or some other signal in lungs, pancreas, etc., etc. A wide variety of abnormal imaging is observed in this disease. So we should be careful about the very similar imaging showing imaging such as multicentric Castleman disease. This is a Castleman disease producing the lymph node producing predominantly IL-6, not IL-4. So if you maybe look at this such a signal in CT, and enlargement of lymph node, maybe enlargement of lacrimal gland, that is also observed in this multicentric Castleman disease. The most distinction between a Castleman disease and IgG4RD may be CRP. In Castleman, the CRP is very high because of high IL-6, whereas in IgG4RD, IL-4 is dominant, not IL-6. As a result, CRP is not so high. Okay, but the imaging is very similar. The histological is totally different from IgG4 on the left side hand, Castleman disease in the right side hand. You maybe look at the description of the histology. In IgG4RD, CD20 positive B cells inside and outside of hyperplastic germinal centers, CD138 positive plasma cell outside the germinal centers. In contrast, Castleman disease, B cells are atrophic, surrounded by a sheet-like proliferation of plasma cells. So, if you check the histology, these two diseases are totally different. The pathogenesis is also different. IL-6 producing cells, whereas this disease, a B cell coordinating with TPH2 to produce IgG4, the cytokine IL-4. So this is a schematic representation of the IgG4RD on the left, Castleman disease on the right. The germinal center is depicted as the red circle here. So this highlights the difference between the IgG4RD and Castleman disease. What about the management of the disease of IgG4RD? There are several domains here. The bile duct, retroperitoneal, aorta, and head and neck, etc., and etc. The main scheme is here. Again, the B cell, along with the Th2 cells, to produce IgG4, leading to plasmacytosis, to become enlargement of lacrimal gland and salivary gland. The most problematic, the sequel, the consequences of the disease is fibrosis. Because of a Th2 response is there. So we need to manage all of these enlargement, becoming of the plasmacytosis, and then leading to the fibrosis. So in order to prevent such the pathogenesis, the most widely used medication is glucocorticoid. So the glucocorticoid are the first-line agent for remission induction in all patients with active untreated IgG4-RD. What about the dose? We surveyed the new onset of IgG4-RD. What about the dose of glucocorticoid are you using in Japanese clinical practice? So this is the result of the survey. The most frequent use of the glucocorticoid is 0.5 to 0.6 milligram per kilogram. So the body weight of Japanese patient is very small, like 50 kilo. So this dose is like 30 milligram prednisone, up to a 60 milligram. But the choice of the glucocorticoid initial induction is like 30 milligram in Japanese RA patients, Japanese IgG4 patients. And what about the high dose versus medium dose for glucocorticoid for induction? This is a randomized clinical trial. The high dose is like 0.8 to 1 milligram per kilogram per day, whereas the medium dose is 0.5. That was most prevalent use in Japan. And the final conclusion, this is small. However, the 20 for high dose and 20 for medium dose, the final result is the effect of remission induction was similar between high and medium glucocorticoid dose. However, the patient with more organ involvement and higher IgG4-RD index score at baseline might get more benefit with high dose. That is realistic. If you start the glucocorticoid, the first line, the middle dose, such as 30 to 40 milligram prednisone for the induction, and then you may taper gradually. However, the 25% of the patients experience flare during the tapering the glucocorticoids. So you need something to add. Immunosuppressant, maybe. So this is the curve. And this is the relapse-free intervals. And we know that the relapse group, 25%, showed significantly higher level of serum IgG4 at baseline, like 816 compared to 346, no relapse. So the relapsers are very high IgG4 at baseline. There are also higher number of organs involved, 5 versus 3. And it is very interesting to look at the lower level of serum IgA. So high IgG4, low IgA at baseline may be a risk factor for flare. We can expect that IgGA are the protection antibody against the mucosal site. So if IgA level, the production of IgA is lower, instead the patient tend to produce IgG4. Maybe, I don't know what is the real mechanism. However, the prognosis of IgG4-RD is somewhat related to the involvement of lymphadenopathy. That is a site for plasmacytosis, right? So if you thought the patient with lymphadenopathy plus here, lymphadenopathy negative here, the relapse of the disease is again dominated in lymph node, lymphadenopathy plus patients right here. So you may be aware the serum IgG4 level at baseline may be lower IgA level at baseline, and lymph node enlargement is a key clinical feature for predicting flare during the disease. So what is the immunosuppressive treatment for IgG4-RD or biological therapy or target therapy? So glucocorticoid is top list, and then cyclophosphamide, methotrexate, reflunomide, tacrolimus here. This is not so well randomized, so we have no approved drug, immunosuppressive agent for IgG4-RD. Finally, the target treatment. Yesterday I received the question, what about the anti-CD20 rituximab for Sjogren's disease? That is not yet approved for Sjogren's, and this is not approved for IgG4-RD. Why? This is IgG for production by B cell. However, the efficacy is not so good, not only Sjögren's, but also in this IgG4-RD. And then the target is shifting from CD20 to CD19. Abatacept also, there is some case report. How should we target this disease, IgG4-RD? The consequences is clear. IgG4 overproduction by plasma cell coming from B cell. TFH2 is supporting through IL4. This is a central scheme of the pathogenesis. How should we manage this? Do you have any thought about this? Rather than CD20, rituximab. Rituximab is not so well working. When you look at the expression of surface molecule in the differentiation of B cell into the plasma cell, you may be aware that the CD20 is expressing in pre-B cell transitional naive germinal center and memory. However, only little or no plasmablast in the plasma cell. In order to control the IgG4 production from plasma cell or plasmablast, CD20 target is not appropriate, right? Instead, CD19 is coming up because this molecule is expressed not only the B cell, but also is expressing plasmablast in the plasma cell. IgG4 is coming from this. So, in order to prove CD90 target is appropriate in this disease, this year, the inebilizumab targeting CD19 showing very good result over placebo right here. So this is encouraging to us to go into the large clinical trial for IgG4-RD. So thank you very much for your attention. This is my final slide. Thank you.
Next, we have the pleasure of hearing from Dr. Daniel Sager, Clinical Assistant Professor at the University of Portland, Oregon, USA. Dr. Sager brings a forward-looking perspective to our discussion as he explores how technological innovation is reshaping practice of rheumatology. His talk, titled Practicing Rheumatology in the AI Era, will delve into the evolving intersection between artificial intelligence and clinical decision-making, highlighting both opportunities and challenges for the future of patient care. I would like to welcome Dr. Daniel Sager to the stage, please.
Assalamu alaikum. Very nice to be here. Thank you for the invitation. Thank you for your very good company these last few days. Congratulations to the organizing committee. What a very impressive meeting. The science has been amazing. It's a high bar to try to reach for me in my talk. Thank you to the chairs, to Dr. Nagat for your guidance and of rheumatology in Pakistan, and Dr. Ahmed for the distinguished position of president of the PSR and the convener of all the work that it takes to put on such a fantastic meeting. These next slides will hopefully not give you the impression that artificial intelligence is here to replace the clinician or the scientist, but instead that AI will be a type of centaur, like a human machine new creature, or a cyborg, like a space person who has to wear the helmet to go into space. In other words, simply another adaptive piece of equipment that human beings have always utilized in getting work done and advancing ourselves and even advancing our science. But the secret, of course, is still going to be the patient, and the teaching of the student and all those things that a machine will never accomplish in any way, anywhere near the same way. So the definition of artificial intelligence can be made very broadly or very precisely. I chose this very broad definition. AI spans any process that involves a machine acting, you could say, like a human. In particular, in its ability to understand language or to recognize images like medical images, even to make decisions, you could say to make suggestions. Chatbots and complex forms of AI learn from their mistakes. They can generate hallucinations, but they can also generate insight in terms of new knowledge unexpectedly. The focus of this presentation is not AI in general. It's much too big of a topic. There are thousands of publications even in the last year. But I'm going to instead focus a little bit more on generative AI. Basically, you could call these chatbots, and how that's transforming how students are learning and how physicians are interacting with patients in the hospital and clinics. And we'll look at some of the risks and opportunities that are related to that. This is just a reminder, artificial intelligence is not intelligent, you could say. It doesn't think. It doesn't really understand. It really has no intention. It's ultimately a human-driven, it's like a rocket going to space. I mean, it's impressive. It does amazing things. We stand in awe of some of the way it speeds things up. But really, it's just simulating and predicting and not really doing anything much more intelligent than that. But as such, sometimes AI appears to have agency. It appears to be a human or to actually be making decisions, and we can get confused by that fact. If you happen to have the pleasure of going to the Jinnah Gardens and taking a walk and looking in the trees to see the birds, as I enjoy periodically doing back home, and if you're fortunate enough to take along your 6-year-old granddaughter, you might find that that child is becoming quite bored quite quickly by her grandfather's activities until you hand her your smartphone and open up the Merlin app, which helps her identify what's in the tree by sound or by image, even by its geographic distribution, where it migrates in the winter, etc. And before you know it, your granddaughter is excited to be a bird watcher. In fact, before you know it, she's identifying the birds faster than her grandfather, who has, of course, much more experience, even better critical thinking skills, you could say, than a 6-year-old. But it's the combination of the joy of the discovery, the joy of accomplishment, that drives artificial intelligence forward. And in that way, it's a very human activity to use a chatbot, I believe. Goethe said, "We see only what we know, and we know only what we see." And ultimately, even with experience, our memory and our experience itself is inherently limited. I think artificial intelligence like these chatbots are really effective, useful to very experienced clinicians, and they're, of course, useful to students or new physicians. But therein lies the problem, that they can sometimes be too efficient, and we'll talk about that a little bit as well. But what's the purpose of these things? Well, we have limited time. There's a shrinking amount of time in clinical life, and we make errors. It's very common. Medical errors cause harm, and any technique that we can derive that reduces the risk of error has to be a good thing. We have to control that application, but it's got to be a good thing to control error. So there's reasons to think about artificial intelligence in areas of the world that have lower healthcare access. Sort of like the smartphone came along and sort of leapfrogged over landlines. I think AI is coming along, is going to leap over a lot of the other things that more developed countries have done in the past. So it's going to be very interesting to see how this goes in African countries and some of the Asian countries that are still developing their manpower. Of course, there's way too much information. No one can possibly keep track of all this. There are many subspecialties. These data are overwhelming. So we have to get some help. The American poet Emily Dickinson said, "The sailor cannot see the north, but knows the needle can." And so a chatbot, really in its best utility, is a compass that helps point the way instead of necessarily telling us that is the place where you're going. It's a device that helps us wayfind. The term wayfinding has been applied to the use of chatbots instead of having answers or firm conclusions. Secondly, the fact of uncertainty is part of life, but uncertainty is harmful to patients. Unmitigated uncertainty is a limbic activator. When your limbic system is activated, you develop other physical symptoms. Your initial disease that's being managed develops other manifestations through the limbic system. So we have to control uncertainty. We have no choice in that. And if chatbots help us do that and do it and help us get the uncertainty under control sooner than otherwise would have been the case, even better. So I'm going to show you a case here. This is an actual patient I was involved with. I typed in this prompt into ChatGPT just to sort of, for amusement, just for the sake of I wonder how the chatbot will do in comparison to how I did when this case was presented to me once back in time. And I'm going to turn this video on now and let it run. But what I want you to be sort of tuned into is how fast the chatbot got to the same conclusion I came to in a sort of a clinical conference setting that probably went on for 45 minutes. And also, I want you to pay attention a little bit to how the chatbot actually shows the transparency of its reasoning. That's a criticism of these things, that they're black boxes and you can't see the reasoning sometimes. But this very simple example shows reasoning. And then finally, I want to point out that the prompt, what I typed in for the prompt, the input, in other words, is super important. Students, inexperienced people are going to, and lay people particularly, are going to put in different types of prompts that's going to give different types of answers, and often erroneous answers. So let me let this run. It's very quick. This is real time. I'm the one scrolling here on my iPhone. And this is sort of how long it took me to just sort of look at the different characteristics of the differential diagnosis, and then a little bit about how the reasoning goes. It let me sort of think to myself, what might it be missing? This is a patient in Kolkata, so I was interested to know if it would talk about India versus the United States. And then before I knew it, it was already telling me these are some of the labs. It wasn't being too rigid. It was being a little bit nuanced about the labs. Here's the hepatitis B screening for this patient. Then it gives me a bottom line. So I think these models are impressive, and they're going to have to be part of they're going to have to be in our control, or they're going to bypass a lot of the things that they really shouldn't bypass. So ultimately, AI, in terms of this type of voice activation or this chatbot type form of AI, is really it's pattern recognition, like my granddaughter on her app, like me with my binoculars, looking for different types of phenotypes, using probabilistic thinking. You could photograph hands of a patient with osteoarthritis and compare it to rheumatoid arthritis, and a chatbot can be trained up to distinguish that, I think, quite quickly, but maybe not able to distinguish pseudo-gout from rheumatoid arthritis. But some of the simpler things, for sure. In addition, a clinical scenario is a type of a pattern. So take-home point, you're going to find that AI performs very reliably in highly structured situations. When you get into complex, nuanced situations, much less so. So for example, clinical reasoning, if it's a CPC, so it's a very rigid type of thing, not a patient in an exam room, like a board exam, imaging, of course, and then histopathologies, physical findings. So it's been said that, really AI is almost risk-free if we can cognitively offload easy stuff to it, things that we consider tasks rather than necessarily things we have to chew on. So, like scribing, you can take your iPhone out, you can lay it down on the desk and interview a patient with this Microsoft software, and studies have shown that it saves the clinician 50% of the visit time. And it produces the document into the computer, weeds out all of the chit-chat that doesn't have to go into the note, and bypasses, so it saves money, saves time. Patient satisfaction with that is really high. We're using that in our clinic in Oregon. But then lots of other things, maybe even parts of medical education can be used for this offloading. There are proprietary curated forms of AI that exist as well. And I'm not going to go into these details too much for the sake of time, but suffice it to say that really this isn't, in my mind, artificial intelligence in the same way that a chatbot is. This is sort of like more like a fast, impressive textbook, with experts curating the information that you're getting. So it's very transparent in terms of what you're getting instead of a black box like a chatbot can be. It's not as conversational, but it can be a little bit in terms of back and forth with the information. And it's less prone to error, so it's safer. And lots of people are writing now that this is the type of AI that needs to be promoted. But the question is it really AI? Or is it just a faster textbook? So-called generative AI is a completely different ballgame. These are some of the terms that are part of that lexicon. If you're reading AI literature, you're going to come across NLP and LLM and GPT, like ChatGPT. But basically, generative AI is the thing that is transforming aspects of clinical care. It's not general AI. The term general AI is the future. That's sort of the scary future. That's referred to as general AI, where computers run amok and they don't have we're not in control of it. Generative AI is a chatbot and things like that. So another type of terminology is a neural network. This has to do with the input of data that's done by humans. Basically, everything on the internet has been inputted into these neural networks. There's very little except obscure things in museums and other places like that that's not in the chatbot world. In fact, chatbot producers are getting sued by people that write novels and other things because their material is just getting taken right into this neural network system. And then the output is the pattern recognition, and that's facilitated by human beings. Like there's a big industry in India of human beings looking at all this output stuff to just confirm that George Washington is actually George Washington instead of Abraham Lincoln or something like that. So there's controversy in this world in terms of how people are being utilized as these annotators for very low wages in parts of the world, maybe even in Pakistan, I don't know, or the United States for that matter. And then there's deep learning, which is so-called unsupervised learning. This is sort of, if you want to ask a question, get more detailed information out of these neural networks, you can look for comorbidities within a diseased population. And that's a whole different type of thing. Really, clinicians like myself are not going to be building these models. These are built by computer scientists, mathematical data management people, and then they're given to us either through research or through industry for us to use. So we have to understand what's going on that end, but that's not the end that we're going to be involved with ourselves. We're going to be on the user end. There's big data mining. That's basically backward propagation, where you get the output and then you run it back through all these neural network nodes and find out what else there is. For example, if you have a lupus patient and they already tried rituximab, now they're going to try belimumab, you want to know what's the chance in which type of patient's going to respond to that. So a little bit like precision medicine, That second example there took 9 million people in electronic health records in the US and UK. And then they found 27,900 with pancreatic cancer. And then they went backwards using neural networks to identify the risk factors and found some patients that had particularly high risk. So this is using AI, not clinically, but more like in research. Dialogue, conversation, that's the heart of what clinicians do. The question is, can a chatbot do it like we do it? If we let the chatbot do it, are the students going to learn how to do it? Or are they going to become less skilled than their seniors because of chatbots? But basically, it's all about the history. It's the nuance of the history, more so than the physical exam, more so than the labs, except for certain uncommon or less common diseases. So this is a study I'm just going to focus on. Came out of a Google research lab. It's been published in the prestigious journal Nature just this year. It's called AMI. It's an Articulate Medical Intelligence Explorer, so it has to do with conversational. You can see, if you can squint and read, the prompt from the human says, "Hi, I'm having chest pain, this and that." And then AMI says, "I'm sorry to hear that you're having this problem." It shows empathy. And then it says, "Well, let me get a clearer picture. Let me ask you some questions." So it's very interactive, just like a physician would be in the clinic. So there are two parts to this publication. I'm going to run those past you. The first study took 20 generalists, and they were randomized to look at 303 challenging real-world CPCs from the New England Journal. These were really difficult cases, like you could say Behçet's or something like that. This was not easy stuff. Each case report was read by two clinicians that were randomized, and they were randomized to two different assistive conditions. One was AMI, and one was sort of standard stuff that you can get in your current practice. And then there was a third arm, which was AMI by itself. So there was AMI reviewing these cases itself with no help at all from a clinician. Then there was a clinician using AMI, and then there were clinicians using standard clinical decision support tools that exist before ChatGPT. This is the result of the first study. There are three arms. AMI by itself was the superior arm. You can see that's in red. And then the second bunching were clinicians assisted by search engines, including AMI, but also the traditional. And then the bottom arm were the clinicians unassisted. So top N, one on the left is if they got it exactly right with one shot, low percentages. Top N 10 is a differential. It was in the differential for 10 choices. So, look at the axis, it's only 60%. It's not 100%. So, everything's imperfect. And this is going to take follow-up, time, calibration, and other things like that. Is AI a calibration tool, or is that the physician? So the second part of this study, they took, these are different text-based clinical scenarios, but these were recruited from doctors in the UK, Canada, and I think in India, from different specialties. They recruited these scenarios. They asked primary care physicians or AMI to give a differential diagnosis, but more than that, also the management. Like how did the computer do as a surrogate clinician, not just differential, but also management. It was text-based. They used patient actors, so it has limitations, of course. These are the results. You may not be surprised to hear, since I self-selected this publication. You have to remember there's some selection bias going on here. I'm not showing all the negative studies. I'm showing the impressive positive ones. But AMI did better than the physicians in multiple different axes, according to the specialist physicians who reviewed the result. They were like the people grading the work of the primary care doctor. But the patient actors also did their own grading. This is a spider diagram to show you how they did. The point of this slide is to show you that AMI outperformed not just on the left for the specialist physician evaluation, like how did they do with their diagnosis, how did they do with the management plan after the diagnosis, but also with the patient actors. These were not virtual patients, these were real people, but acting as a patient using those text-based scenarios. They found that the computer did better than the clinician for things like empathy and openness and honesty and confidence, which is really alarming, isn't it? Because, you know, maybe this is rigged, you know, by the study design and you get the result you want. But there's some reality here that maybe clinicians need to do a better job with empathy, or a computer's gonna beat us out. You know, we have to sort of be good at what we know we can do well. Okay, last couple slides and we're done. So what could possibly go wrong with you using a ChatGPT in your medical school or in your clinic? These are some of the types of things that happen with artificial intelligence. And AI uses contemporaneous knowledge. It doesn't use stuff that hasn't been discovered yet, of course, but it gets into AI quickly. It's a bit of a black box, and so that can predispose your results to the risk of bias. There's all different types of bias. Hegemony is a big worry, I think, for people that are in countries that are not developing these systems. So how well does this apply to your culture, your economics, your academics, your pharmaceutical industry? You know, where is the hegemony coming from? You need to know that. And then it can be difficult to apply this to underrepresented groups, as shown in the reference I've listed there. That's called data shift. I've touched on never skilling. I'm not going to go through this again very much because we've alluded to it, but basically offloading the hard stuff in medical education, offloading your own professional development, your own metacognition, your own independent problem solving is very risky, and that can cause this thing called never skilling or de-skilling. If you already have skills, you can become de-skilled with overuse of AI. And then there's the issue of, you know, what about local context like epidemiology? You guys see patients late, maybe a little bit more than we do. We see people early in the course of disease, maybe a little bit more than you do as a whole, and that really affects prompts that you put into your chatbot as well as answers you get. This is a real patient that I saw, and I'm just going to let you see how this gets complicated. It started out with neck and back pain, and over the years, this is what this poor person had developed. How is a chatbot going to handle that? So it doesn't address reality, or is it just address scripted situations? So someone has said this should be for wayfinding, not a rigid conclusion. And the other quote is the mistake of starting with the answer instead of using it as a guideline. So will humans be necessary? Of course. You're not going to get in an airplane anytime soon, I don't think, without a human being in the cockpit, although we do get in trains in Zurich without a pilot in the front of the train. So this is a slippery slope, and you know, fortunately in the near term we're going to be necessary to be sure that the answers we're getting from our prompts and from our students' prompts are accurate answers. Thank you very much.
Thank you so much, Dr. Daniel Sager, for such an enlightening talk. Continuing with our scientific deliberations, we are honored to welcome Professor Tore K. Kvien, Professor of Rheumatology at the University of Oslo, Norway, and former president of EULAR. Our distinguished leader in rheumatology, Professor Kvien has made remarkable contributions to advancing clinical and translational research in the field. His talk, titled Changing the Paradigm in Osteoarthritis from Symptom Control to Disease Modifications, will shed light on the evolving understanding of osteoarthritis, focusing on the strategies that move beyond symptom management toward true disease-modifying approaches. Everybody, give a huge round of applause for Sir.
So good afternoon, and thanks again to the organizers for inviting me here to beautiful Lahore. We had a fantastic evening yesterday with some sightseeing for the non-Pakistan persons. So thank you very much. And secondly, I have enjoyed the meeting also very much, so that's also a pleasure for me. So you see the title of this talk, and I should actually have added a question mark after the title, I think, because as you will hear, we don't really have any disease-modifying agents for osteoarthritis yet, but I will go through some of the work that has been done to really to try to find such agents. Sorry. No. This one? Yeah, okay. So these are my disclosures. Nothing is relevant for this talk. So I should perhaps have used artificial intelligence for this talk, but I didn't. But the previous speaker would have inspired me to do that. But instead, I asked my fellow colleague, Ida Haugen, who I supervised to her PhD more than 10 years ago, and now she's a professor, and she is also one of the leading experts in osteoarthritis, and especially hand osteoarthritis in the world, and she helped me with some of the slides for this talk. So I just start here with some data from Pakistan. You know, there is something called the Global Burden of Disease Project, where they assess the burden and the prevalence of diseases across different countries. And as you can see on this slide, with the rising curves, that also osteoarthritis is increasing here in Pakistan. Even if you compare Pakistan with other countries, you see that it's lighter color here. So from these data, osteoarthritis is less prevalent in Pakistan compared to at least European countries and some other Asian countries, as you can see. But still, it's a problem. We have, as I mentioned also in my talk in the opening session, that we have guidelines and recommendations to support our work, and that's also the case for osteoarthritis. But you will see if you read these guidelines, for example, from the Osteoarthritis Research Society International, you will see that they have a most focus on mild symptomatic agents like topical NSAIDs and perhaps systemic NSAIDs, but there is nothing about disease modification usually, and also some skepticism to paracetamol, even if I think most of us are using that, skepticism to glucosamine and chondroitin sulfate, and there is a much focus, and what I think also is very important, is the non-pharmacological management of osteoarthritis. So there are several definitions also of disease-modifying osteoarthritis drugs. We are used to, in rheumatoid arthritis, we call them disease-modifying anti-rheumatic drugs, DMARDs. In osteoarthritis is the DMOADs, disease-modifying osteoarthritis drug, which are disease-modifying drugs that would inhibit or even reverse the progression of osteoarthritis. And since the main hallmark of osteoarthritis is cartilage loss, a typical disease-modifying agent would prevent the loss of cartilage and potentially reverse it. So why is then development of disease-modifying agents in osteoarthritis a big challenge, an unresolved challenge? I think there are several reasons. First of all, osteoarthritis is a very heterogeneous disease with different phenotypes. And it's not only a cartilage disease, it's a whole joint disease, as I will show you in a second. And another issue is that the regulatory agencies to approve a disease-modifying agent for osteoarthritis, they require both a structural effect and a symptom-modifying effect. So it's not enough to reverse cartilage degeneration. You also need to demonstrate some effect on pain and function, for example. And the endpoints are also a challenge, whether you should use a clinical endpoint, joint replacements, or imaging endpoints. And usually, I think you consider imaging endpoints for disease modification in osteoarthritis. And then another issue is the long-term aspect, to show effect on cartilage degeneration. You need observation times, not only for days or weeks or months, but even for years. And that is a big challenge. And then you have different endotypes for candidate disease-modifying agents, which I will show you very soon. So I remind you about the different phenotypes. It's knee OA, hip OA, hand OA, and the generalized osteoarthritis, as you can see here. So that's typical. And then I said it's a whole joint disease. So you can see here on this slide, it's a degeneration of the cartilage. And then you have the formation of the osteophytes. You have the subchondral bone density. And then you have also formation of synovial fluid because you have a secondary inflammation. So that's what's happening within the osteoarthritic joint. And then coming back to the endotype. So I think that when you consider disease-modifying agents in osteoarthritis, you focus on three different aspects. One is the cartilage, another is the bone, and the third is the inflammatory changes that you have usually a secondary inflammation in many patients with synovitis and formation of joint fluid. So if we start with the cartilage-driven endotypes, there are several potential targets, as you can see here on this slide. So I think none of them has really been very successful, but one which has shown some effect is the structural effect of interarticular spriformine. So these are data from a study that was published, 5-year observation study, demonstrating in 5 years, that's a long time for a study. And this drug, spriformine, is administered intraarticularly. So these were the knee joints, and it demonstrated some structural effect on the cartilage, but not very much, and very minor effect on symptoms. So I'm not sure about the current status of this drug, but anyway, the effect is rather moderate or mild. So maybe it will be much, not be cost effective, for example. Another target regarding cartilage is the Wnt signaling. And then you have a drug called lorazepam. And there have been at least 2 studies published in clinical and experimental rheumatology, also with a disappointing result, no definite effect on structure modification and no definite effect on symptom modification. So in summary, these targets of the cartilage, it has mostly failed. And then is, of course, the question, what about glucosamine and what about chondroitin sulfate? And that is really a difficult issue. There were originally some promising studies also showing some structure modifying effect of glucosamine, published many years ago. And then in the United States, they took the initiative to do a big study, the GATE study, comparing glucosamine, chondroitin sulfate, a combination of both, and with celecoxib and with placebo. And this was a completely negative study. The only effect was actually seen for celecoxib. But saying this, there was also a very strong placebo effect in this study. But altogether, I think that all societies, both EULAR, ACR, maybe APLAR, I don't know, Osteoarthritis Research Society, they have concluded that there is no real benefit of glucosamine and chondroitin sulfate. But on the other side, it's not very much side effects either. So I think for most patients, many patients are using these agents, and they usually don't do any harm, at least. And for chondroitin sulfate, we published in the Annals of Rheumatic Diseases some years ago a study from Jean-Pierre Pelletier's group in Montreal, showing that in this study, where he used MRI as the endpoint, he was able to show that chondroitin sulfate compared to placebo had some effect on cartilage damage and had some effect also on bone marrow erosion. But many other studies have been completely negative, so the conclusion is that chondroitin sulfate is not any really strong drug for osteoarthritis. So then the second endotype that is important to consider is the synovitis-driven endotype. And there we have more the agents that we are used to in treatment of rheumatoid arthritis. But again, the results have been overall rather disappointing. So there have been studies with hydroxychloroquine, and this table to the right, you see no, 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 no. Oh, sorry. That's very right. No, 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 here. So these studies did not show any clear effect in hand osteoarthritis. And again, it was a thinking from rheumatoid arthritis that some of these agents considered as disease-modifying agents in RA could also be effective, especially in hand OA. And you had the METHODS trial, which was on methotrexate, showing some symptomatic effect, but here the structural endpoints were not the major things. And then there have been other studies on methotrexate, both in knee and hand osteoarthritis, showing maybe some symptom-modifying effect, but no clear evidence on structure. And there are still other studies. We are, for example, doing one study on methotrexate versus placebo in hand OA in our department. So we have not lost the interest in methotrexate as a potential disease-modifying agent, and we are also then using MRI and ultrasonography to assess whether there is any structural effects. So this was from the meta-analysis with methotrexate across different phenotypes in osteoarthritis. And then there have been studies with biologic DMARDs in hand osteoarthritis, adalimumab and interleukin-1 inhibitors, and etanercept and tocilizumab. And overall, this has also not shown any effect, neither on structure modification nor on symptomatic benefits. Some symptom-modifying effect, but not very convincing, actually. So in summary, the efficacy of DMARDs that we consider in rheumatoid arthritis, in hand osteoarthritis, has been rather disappointing. Some evidence for adalimumab in one study from Belgium, that's what is indicated here, and some symptomatic evidence in some studies with methotrexate. And then we have the interleukin-1 inhibitors, which may be perhaps more convincing. There has been studies with interarticular anakinra, not shown any clear evidence of benefit. There has been with the interarticular canakinumab, also showing no clear evidence or benefit. And then there is one study, one drug that I think was developed especially for osteoarthritis, and that's lutikizumab, which was an inhibitor both of interleukin-1 beta and 1 alpha and 1 beta. But again, the results were disappointing, both regarding structure modification and regarding symptom modification. And this is also from a phase 2A placebo-controlled study with lutikizumab that was published in ARD, also with a disappointing result. But then there are two other studies that are rather interesting, actually, because that was studies with thousands of patients looking at interleukin-1 inhibition and effect primarily on cardiovascular endpoints. But then, since you had such huge population, and also in a population with the risk of osteoarthritis, that means elderly people. So the CANTOS study that was published in New England Journal of Medicine, there was a post hoc analysis where they looked at joint replacements And what you can see here is that the patients who received canakinumab, the interleukin-1 inhibitor, they had less joint replacements, that's what you see here, than the patients who received placebo. And then there was another study also looking into cardiovascular prevention with colchicine, also a huge number of people participating in the study so that they could do a post-hoc analysis looking into joint replacement, and also here showing some differentiation in the direction of less joint replacements in the patients who had been exposed to colchicine compared to the patients who had been exposed to placebo. But I think, for a practical clinical standpoint, you would probably not expose your patients to an expensive drug like canakinumab or to colchicine just to prevent joint replacements, and the effect is not clearly demonstrated since this was also a post-hoc analysis, but it is interesting and indicating that perhaps inhibition of interleukin-1 could have some structure modifying effect and prevent joint replacements in osteoarthritis. And then finally, we have also the bone-driven endotypes, and there are different also here targets that have been considered. So the only one that have demonstrated some effect is actually denosumab, which also demonstrated a structure modifying effect in rheumatoid arthritis, but no symptom modifying effect in rheumatoid arthritis. And it was actually the same in hand osteoarthritis. You had less cartilage damage and bone damage with denosumab compared to placebo, but no effect at all on symptoms. So that means from a regulatory standpoint, as I mentioned in the beginning, then denosumab will not be approved as a disease-modifying agent for hand osteoarthritis. And then we have strontium ranelate, where we published in ARD some years ago a study from Jean-Yves Register showing that strontium ranelate actually had an effect on cartilage damage, but and also had some effect on the WOMAC scores, but strontium ranelate is associated with some severe cardiovascular risk, so it's not relevant for clinical use, but at least this was shown to have some effect both on symptoms and on structure in knee osteoarthritis. So in conclusion, randomized controlled clinical trials with potential structure modifying effects have overall failed, both regarding structural and clinical endpoints. Sprifamine has some effect on cartilage volume on post-hoc analysis from the CANTOS, and the colchicine study indicated some reduced chance of joint replacements. But overall conclusion is that unfortunately disease-modifying osteoarthritis drugs is currently not an accepted treatment option for patients with any of the phenotypes of osteoarthritis. So thank you again for inviting me here, and thank you for your attention, and enjoy the rest of the Congress, just a few hours. Thank you very much.
Yes, sir. Up next, we have Dr. Suleman Khan, consultant, rheumatologist, NHS UK, who brings extensive clinical expertise in the management of autoimmune and inflammatory joint diseases. His presentation titled, "Should JAK inhibitors be preferred over TNF inhibitors as first-line biological therapy in rheumatoid arthritis?" will delve into one of the most debated topics in modern rheumatology, evaluating efficacy, safety, and long-term outcomes to guide optimal therapeutic decision-making. Welcome, sir.
Assalamu alaikum, everyone. You all might be hungry as well, and it's quite challenging to do the presentation just before lunch, but I'll try my best to to finish the presentation within allocated time. Thank you to PSR for this invitation, and it's a pleasure to be part of this great Congress. No disclosures, but looking at the topic itself, should JAK inhibitors be preferred or TNF inhibitors as first-line biologic therapy in rheumatoid arthritis? I think it's quite fascinating and perhaps a hot topic in our sort of scenario over here in this country, considering various challenges, starting from availability of biologics to cost effectiveness and affordability. So let's just go through a few things. So you are sitting in a busy, bustling rheumatology clinic, and you get Sarah, who is a 35-year-old lady, active professional with no comorbidities, doing well on upadacitinib. With a disease activity score of 2.3, she's happy with things, and you're happy as well, so all good. In contrast, John is a 67-year-old gentleman. He is a retiree with a history of smoking, cardiovascular problems, including hypertension, and he also had myocardial infarction a couple of years back, experiencing some pains, but no evidence of actual synovitis with a disease activity score of 2.1. He's well maintained on adalimumab and no issues in terms of side effects. So both patients are essentially doing well. They're happy and you are happy. So we will leave it there and proceed with our objectives. Over the next few slides, we'll just discuss some basics. But then we'll compare the efficacy of the two classes of these important medications that we commonly use, JAK inhibitors versus TNF. And we'll have a look at the safety profile and then consider the cost effectiveness as well at the same time. So rheumatoid arthritis, you all know that it is symmetrical polyarthritis, which causes inflammation of the synovium through different cytokines, interleukins, and TNFs, tumor necrosis factors, causing inflammation, pain, swelling, and stiffness. And the idea is that we control the inflammation, having this objective in mind to minimize pain, swelling, and stiffness, along with erosions and long-term comorbidities, and improve the quality of life. So usually, the first line of treatment includes corticosteroids. We use methotrexate quite a lot as well in combination with other DMARDs. But then at some point, you require to escalate the treatment, and biologics are thought to be required in 30 to 40% of rheumatoid patients, typically after methotrexate failure. Then you have to make up your mind really as to what class of medication you would want to go with. In countries like the United Kingdom, the NHS has strict protocols most of the times, and we follow that. But in countries like ours here in Pakistan and perhaps other countries where you are stuck with various issues, starting from availability of various molecules, but also the cost of these medications, you have to make up your way to decide what is the best course of action in terms of choice of medication. So TNF, you all know, I don't need to spend too much time on this, but the ACR 20, 50, and 70 responses are 50 to 70% at 6 months, and sustained remission along with methotrexate in 20 to 30%. Subcut and intravenous forms are available, and with the availability of biosimilars, there is some cost effectiveness addressed, but still it's a bit of it's quite a bit of challenge rather. Usually established as common first line, but the good thing is that we have extensive experience with TNF when it comes to safety, data, and real world experience. JAK inhibitors block JAK state pathways, and tofacitinib, baricitinib, and upadacitinib, filgotinib as well, I should mention, are the different molecules that are commonly used. These are usually with rapid onset within weeks, oral route of administration, and that improves adherence. And there is definitely evidence of efficacy in methotrexate refractory rheumatoid patients and can be used as monotherapy as well. So you use methotrexate, you use steroids as I mentioned, but then at some point when the disease activity score is high with a significant number of tender swollen joints and higher DAS, in the UK, if the disease activity score is more than 3.2 at 3 to 6 months interval where the inflammation is definitely there, you would want to escalate the treatment. The first biologic is usually the TNF historically, as I mentioned, but now as things are changing and we have availability of more molecules in the form of JAK inhibitors, these are considered effectively as well. And I was just talking to Professor Suleman, and they use quite a lot of JAK inhibitors in Iraq as well. Switching strategy is there. So sometimes when the patient is started on one molecule, one medication, you can switch within cycle and between cycles as well. So you can change from one TNF to another one, and you can change from one class to another class, meaning that you can switch from TNF to JAK inhibitor. So early rheumatoid arthritis, less than 6 months, there is intensive escalation. You probably would remember the Takeuchi studies, which suggested that rapid escalation helps. And that has been a historical approach when it comes to management of rheumatoid arthritis. And the idea is to prevent erosions and disability. But methotrexate failure can happen, and less than 20% improvement in these patients where you don't really see any significant improvement in terms of tender and swollen joints, and there is persistent disease activity, you then want to escalate treatment. But definitely you would want to consider patient factors, and the economics come into play as well. So the choice of medication is influenced by 3 important factors. One is the efficacy, second one is the side effects profile, and the third one is the cost effectiveness. When it comes to efficacy, there is head-to-head trials, but these are rather limited RCTs and supplemented by some network meta-analysis. So the select compare suggested that upadacitinib was superior to adalimumab with the ACR of 70% versus 56% at 12 weeks. Oral study, tofacitinib and methotrexate was non-inferior to adalimumab and methotrexate. And then the RAB, baricitinib, was superior in remission rates, 55% versus 49% in comparison to adalimumab. So looking at this slide, there is an edge for the JAK inhibitors, shall we say. The meta-analysis from 2024, JAK inhibitors superior in improving health assessment questionnaire HAQ scores. However, there was no significant difference in clinical disease activity index. There was slight deterioration or worsening of the visual analog score, the pain score, but overall edge in functional status and activity reduction for JAK inhibitors. 2025 updates confirm comparable or slight JAK inhibitor superiority in pain and remission. So as we discussed, HAQ does improve with JAK inhibitors, more so in comparison to TNFs. Remission is more seen with JAK inhibitors, 30 to 40%, versus 25 to 35% in TNF blockers at 1 year, and this is the meta-analysis. Monotherapy as well, JAK inhibitors are rather superior, especially in methotrexate intolerant patients, and also JAK inhibitors, because these are oral, these improve quality of life and adherence as well. So quite a few positive things about JAK inhibitors, shall we say. The next thing that I mentioned was safety. So whenever we choose our medications, we want to make sure that these are safe and the patient does benefit without being harmed or subjected to a lot of immunosuppression, particularly if they are prone, if they are diabetic, if they are having recurrent infections, if they are having COPD or low immunoglobulins, you name it. There's a lot of scenarios where your patient can be prone to infections as well. So the pool hazard ratio, there is no significant difference in serious infections when we compare JAK inhibitors to TNF. The real-world BioBedasser from 2023-2025 suggested similar rates when it comes to infections. But of course, you will consider risk factors, and one of the risk factors is age of the patient. If they are more than 65 years of age, if they are concomitantly on steroids, and also history of TB, etc. But you certainly would want to exclude all those infections by mandatory TB and hepatitis screening. The cardiovascular side effects profile is important, and it historically has been mentioned over the last few years that there has been increased incidence of MAS with tofacitinib in high-risk patients, particularly those over 50 years of age and those who are smokers. So you have to be mindful while you want to prescribe tofacitinib or any JAK inhibitor for that matter. The 2025 meta-analysis, however, suggested that there was no higher cardiovascular event associated with JAK inhibitors in comparison to TNF. But again, frailty needs to be adjusted with similar incidents in the elderly, but at the same time monitoring the lipid profile, blood pressure, etc. Needs to be ensured. In these individuals where you feel that they are at high risk of infection or keeping in view their age or prior history of any venous thromboembolic events, you would want to go with the TNF rather than JAK inhibitor. Malignancy risk, EULAR data 2024-2025 suggested that there was no risk, increased risk overall with JAK inhibitors versus TNF. But if a patient has got a history of solid tumors, the suggestion is that we prefer TNF blocker just because we have long-term data available to us because these medications have been in practice for a long time in comparison to JAK inhibitors. JAK inhibitors, if a patient has got a history of lung cancer, then you would want to, and if they are smokers, you want to exclude those and go with the TNF. Skin cancer, caution with JAK inhibitors in patients with a history, but long-term data again suggested that there was not much difference between the two classes. So as such, we do not really see a huge difference between the two when it comes to malignancy risk. Other adverse events of special interest, venous thromboembolic events, slightly higher with JAK inhibitor, but low absolute risk, comparable overall. Those with high BMI and prior history require careful monitoring. Herpes zoster was thought to be higher in patients with JAK inhibitors, 3 to 4 times higher risk, and definitely recommendation is to have these patients vaccinated before starting the therapy. There has been some rare and some cases of GI perforation, and if your patient has got a history of diverticulitis, they say that we should avoid these. And of course, lipid profile, hyperlipidemias, hypertension, cardiovascular events, angina, MI, etc. You would want to monitor those and then go with the safer option of TNF blockers. But you need to be aware that these medications can lose efficacy with time, and TNF blockers can develop antibodies. Filgotinib is a good one. And I think it's probably coming into market here. I'm not sure whether it's available or not. And it has got similar sort of efficacy when it comes to its comparison with other JAK inhibitors. There has been real-world data to suggest that there is 65% low disease activity and remission at 6 months, and quite comparable with other JAK inhibitors. But the good thing about filgotinib is that the risk of herpes zoster which is thought to be dose related, as we know that it comes in 2 doses, 100 milligrams and 200 milligrams. But when compared to placebo, there was no significant herpes zoster risk, and obviously vaccination is recommended. So that's a good one in comparison to the other JAK inhibitors. So the real world data from 2023-2025, the biobedasser suggests that JAK inhibitors are effective with low adverse events of special interest in low-risk patients, and TNF are better retention in high-risk individuals. Also at the same time, if you are switching JAK inhibitor after TNF failure, it yields 65% of low disease activity versus TNF cycling. So if you are changing an anti-TNF to another anti-TNF, you might see less success in comparison to switching from TNF to JAK inhibitor. And adherence, of course, is very, very important. In the UK also, we save money because if you are giving an intravenous infusion, patient has to come, and that involves some cost as well. And I'm sure it does over here as well. So oral medication, people prefer it as well. There is convenience. And that's why JAK inhibitors, there is 85% 1 year adherence in comparison to 70% for the TNF. So the EULAR suggests that targeted therapies should be on the basis of individualized approach, considering cardiovascular malignancy and infection risk. And if that is the case, then you will go with TNF blocker or even interleukin-6 inhibitor in patients who are having significant risk factors. JAK inhibitors are good alternatives, particularly if you have exhausted other options, namely anti-TNFs, and also if the patient is low risk. But as a matter of fact, you need to involve your patient as well. And one of the involvement in this country, in Pakistan, you know, when you ask them, because patients will be sort of paying for themselves, they, you know, when you involve them, they will go with the less costly treatment. But that's important because at the end of the day, it is them who pay for their treatment most of the times, unfortunately. Post-cancer, there is no delay in remission. So when it comes to starting medications post-cancer, we do not necessarily need to delay the treatment with whichever option we go with, but TNF is preferred in solid tumors. The ACR and expert consensus from 2024-2025 suggests that TNF should be the first line and JAK inhibitor for inadequate response, but we need to be aware of the cardiovascular and malignancy caveats. The immune-mediated inflammatory diseases experts consensus, JAK inhibitors are safe according to that and effective as well, but we need to monitor for the AESIs, and these are preferred in low-risk patients. EULAR suggests that there is equal efficacy, but TNF for frail and high-risk patients, and there is no overall cancer signal. So the same thing, low-risk individual prefer JAK inhibitors, high-risk individuals, TNF is the safer first option, but consider comorbidities in all your patients, and there is some preferences for oral in low-risk patients. TNF are injectable and involves cost as well. So the long-term outcomes can be affected. And cost effectiveness is very, very important because I mentioned it before. I think the cost of JAK inhibitors here is like somewhere between 5,000 to 6,000 rupees a month now. In comparison to for the TNF, I think it is just over 40 or 50,000, perhaps in some cases. So there is quite significant difference. And if you consider that, if your patient is low risk, then obviously you will go with the JAK inhibitor. So the efficacy is important. Safety profile needs to be taken into consideration. And we need actually more studies, head-to-head trials, to come to some stronger conclusions, but for now, this is what we have got. So the idea is the concept of personalized care. No single therapy fits all. What works wonders for one may pose challenges for another, highlighting the essence of personalized treatment, tailoring choices to individual risks, preferences, lifestyle, and ensuring optimal outcomes, reminding us that everything is not applicable everywhere. So, what will you choose? So you need to raise your hands then, okay? So Sarah is a 32 years old lady. She has got active rheumatoid arthritis with a disease activity score of 5.7. She had a history of PE 2 years ago. She is diabetic with HbA1c of 7.4 and also had significant preeclampsia during her last pregnancy. She has been having regular blood pressure monitoring, and today's her blood pressure in your clinic is 149 over 95. What will you choose? Just say TNF or JAK. Who goes with the TNF? Okay. And who goes with the JAK inhibitor? Right. Okay. So very, very good. Well done. Now, John is a 45 years old gentleman, and he has failed methotrexate, and he has had 2 anti-TNFs already. His current disease activity is 6.3. He has no comorbidities. But there are 2 scenarios. One is John 1 is a businessman in central London. He can afford any treatment. What will you go with? TNF or JAK inhibitor? If he can afford, he has got no affordability issue. He tells you, doctor, give me the best treatment and the safest of all. Very good, I agree. And if he's someone, in another place, he has no job, John 2, and, he says, doctor, I'm stuck, I've got to pay for my mortgage, and life is tough. Write me something because I don't have insurance. I'm not being treated in the NHS, so write me something which can help me, considering my situation. What are you going to go with? Excellent. So we learnt it all. Thank you very much indeed. Thank you.
Thank you so much. So I'm taking the liberty to thank, on behalf of Professor Amjad, Dr. Shabir, Dr. Asadullah, for having us chair such a fantastic session. Thank you to the speakers, but we are short of time, so we invite all questions to be put to them personally later. So we're going to move on to the next session. Thank you so much.
Thank you to the speakers and the chairs. I would like to request Professor Nigat Mir Ahmed, Patron-in-Chief, and Dr. Ahmed Said, President and Convener of PSR, to present tokens of appreciation to our speakers.
आप बस speakers को दे दो ना, हमें ना दो.
Professor Sikandar Afzal, who is Associate Dean of University of Lahore, who is here, and University of Lahore is also one of our collaborators because this conference has been accredited by University of Lahore for 15 CPD hours. We thank you, sir, for being here this afternoon, and we would like you to join us on stage for the souvenir distribution.
Takeuchi. I would also like to request the chairpersons to present the token of appreciation. Daniel Sager. Dr. Torre K. Kvien. Dr. Suleman Khan. Now I would like for Professor Nighat Mir Ahmed and Dr. Ahmed Said to present a token of appreciation to our chairpersons. Thank you. Please note that
I would like to present a token of appreciation to our Professor Sikandar Afzal, Associate Dean, University College of Medicine and Industry.
Please note that the Rheumatology Gastroenterology Board has begun in Crystal Hall A, while Rheumatology Infectious Disease Board will now begin in Crystal Hall B. Thank you.